forward or backwards, or because I can barely see myself.
And we're live. And we're live. Hey, welcome back, everybody. You know, it's 2020. It's hard to believe. You are here with Alice Crisci, founder and CEO of MedAnswers, and the Fertility Answers app, and my dear friend and colleague, and the incredible IVF doctor, Dr. Serena Chen out of Livingston, New Jersey. We took a couple of weeks off. I'm happy that we did. We recharged, and I spent some time thinking about how we can deliver the best conversations to you. And one of the ways that we want to do this is at least once a month, if not every single week, bring an actual case study to you. And I have a very sad story that unfolded over the holidays with someone very dear to me, Serena, and that's what I want to talk about today.
Okay.
A very close friend did I think 3 rounds of kind of light stimulation, and we'll get to what that means in a second. But she is 44 years old, super healthy. She's an acupuncturist herself. She, so many clean things that go into her body to prep for having her second child with her newer husband. And at 12 weeks, just about 12 weeks, she actually did have a bleeding episode. Copious amounts of blood. I mean, as she explained it, 3 toilets full of blood, and then went in for a sonogram. Everything was fine. But then 2 days later, she did experience a devastating 12-week pregnancy loss. And
I'm so sorry.
Super, super heartbreaking. So, in particular, because it was also a genetically tested normal embryo.
Yeah.
He did all the right things.
Yes. Yeah, I know. So I'm so sorry, Alice.
I appreciate that. And really so many people in our community who know this exact devastation, who have been through it. Now, there was so much blood loss. She actually ended up with 2 blood transfusions. So I wanted to even start there. I wanted to kind of break down the biology of a pregnancy loss so that people truly understand. Some of our users, of course, have endured, like me, multiple chemical pregnancies, and they're no less devastating than any other loss. There's no contrast. There's no comparison. There's no my loss is bigger than your loss. We treat all losses as devastation. And I'd like to understand, what the impact is in terms of the human body when there is a loss. I think, there you are, you're back. I want to talk about the impact on the human body when there is a pregnancy loss.
I'm back, but for some reason,
it's okay. We can see you, so don't you sweat about seeing me. You don't need to see me. You know what I look like.
Okay.
So you talked to us a little bit about what the impact on the body is. What happens when a miscarriage is unfolding, whether it's a chemical loss or it's a 12-week loss or it's even a devastating 20-week loss. Can you take me through the kind of the human biology of what the body goes through when there is a loss?
So biochemicals, I think we have to put in a separate category because not sure they're the same thing. Like what we're finding with PGT, which is very puzzling, is that we don't seem to be impacting the rate of biochemical losses, which is
interesting. Okay.
Frustrating.
Yeah, very frustrating.
On the other hand, the good news is that biochemical losses many times are a good prognostic sign. Like they can be a sign that everything's okay, everything's working, you got at least 1 egg and 1 sperm through 1 tube, and you had some implantation. And we know that biochemical losses occur very, very frequently in the fertile population without a lot of people knowing about it. So I'm not sure we can put biochemical losses into the miscarriage category. At the same time, there's still a lot we just don't understand about them. The vast majority of miscarriages will occur between 6 and 8 weeks, and then the rest of them, the vast majority occurs before the end of the first trimester at 14 weeks. It's a very low number that occurs beyond that, but obviously that can be extremely devastating.
What is that magic when you're at week 12, Serena, whenever, when sort of the old school thing was don't tell anybody you're pregnant until week 12. But if the end of first trimester is week 14, what is it that we're worried about, as we, make it
we're still concerned about genetic abnormalities and things like that, even in a PGT normal pregnancy. And, so you could, while most aneuploid losses will occur like, by 8 weeks, that's not always true. And obviously a lot of times in the United States, we're doing prenatal testing at week like 11, 12, 13. And that's when we can find out about Down syndrome and Turner syndrome and things like that. And again, PGT is supposed to dramatically lower those risks, but PGT is not 100%, and so there could still be something that wasn't picked up, or like some lower level abnormality that was not picked up by the testing that might lead to a loss at a later date. Sometimes we don't get the answer, but most of the time, most losses, the cause is more on the embryonic side rather than on the maternal side. Um, Now, having said that, we obviously want to look at everything on the maternal side and on the embryonic side to try to figure out what happened and can we prevent it, or was it just like really, really bad luck? I think that, someone like your friend who's had a baby before, she had a baby before. Yeah, so she had a healthy pregnancy before. So most likely this was something going on with that pregnancy. Now, having said that, obviously so many things can change from one pregnancy to the next. So we can't, take that for granted. She has to have a full evaluation. And pregnancy can involve tremendous amounts of bleeding normally, like with a delivery or a DNC or with a loss, because your body ramps up the amount of blood you make and all your blood vessels get dilated. You just, any kind of procedure or anything like that, people do tend to bleed a lot. That's the nature of pregnancy. But having that much blood loss and needed to get a transfusion in a healthy person, I think, even though it's her second pregnancy, this is probably a little bit of overkill, but there are some people with von Willebrand's, which is a genetic congenital condition, that present this way later in life. The vast majority of bleeding disorders, von Willebrand is one of the most common. It's considered to be a bleeding diathesis, where somebody tends to bleed more. It's a genetic condition, but von Willebrand's is a little odd in that it can present later in life, and it can be episodic. Like sometimes you make plenty of clotting factor and sometimes you don't. And if you happen to be having something bad happen, like a pregnancy loss, at the same time as your clotting factors are low, that can lead to something, like a lot of blood loss and blood transfusion. So I feel like testing for that is super simple testing. So you see a hematologist, they test you, they say, most likely they're going to say, oh, you're fine, you don't have a bleeding disorder. But I think it's always a good idea to check for that. This is why we also don't want people to be taking this is one of the reasons you don't want to be just taking aspirin or NSAIDs or anything like that over the counter without talking to your doctor. People that are taking a lot of supplements, excessive amounts of green tea, fish oil, can theoretically, for some people, lead to excessive bleeding. Sometimes it's just bad luck, but all of those things are worth thinking about and looking at in terms of the blood loss. So we definitely think of, most of the time, first trimester loss, we feel even at 12 weeks still most likely is more embryonic, more on the fetal side than on the maternal side. When you're going into the second trimester, which becomes much more rare, we definitely want to look at them. It's still a lot is due to the pregnancy itself rather than the mother, but we obviously still want to really thoroughly examine everybody, because it's kind of a rare thing to see that.
Right. So let's break down actually what PGT does tell us and what it doesn't tell us. Because I
So
think
PGT A is PGT aneuploidy. That's one of the most common types of PGTs done. And when you do PGTA, it means your embryo theoretically all the cells should be 46XX or 46XY. And you should have exactly the right amount of chromosomal material. And that's so helpful because at least 25% of all pregnancies conceived will have an extra or missing chromosome, and that can lead to most likely to first trimester loss. So knowing that your pregnancy has the right number of chromosomes means that your pregnancy loss rate should be reduced theoretically to around 8 to 10%.
Let's underscore that though. So it doesn't reduce the pregnancy loss rate to 0.
No.
When you say it's not 100%, you still run a risk of miscarriage of 8 to 10%. And does that increased risk of miscarriage elevate with our older age? I mean, you see these moms, these grandmas who are 30.
But I believe that it does. I feel like we see trends towards that, but we don't have a lot of over 40 data with PGT because in order to do PGT, you need a lot of embryos and they need to get to the blastocyst stage, and a lot of 40-something-year-old patients will not. Just as you get older, you just make less eggs. So it's harder to get to that stage. So I don't think our data is so good, but we do believe that those kinds of abnormalities, maybe the loss after PGT does seem like it gets higher with age. So there does seem to be other things going on other than just the aneuploidy testing.
Sure. So somebody in my case who's 43 wanting to do another embryo transfer this year, I need to look at that too, right? I mean, I have, they were PGS embryos back then. They're all normals, but maybe it's warranted to do some extra testing or something before I go ahead and embark on it. Or since I have
your embryos, well, if they were done a while ago, if the PGS was done a while ago, we don't.
12 years.
Depends on the technology, right? Was it FISH? Was it CGH? Was it SNPs? Was it like NGS? Was it, how were they tested? Because testing a few years ago is different than testing now, although still very, very helpful. And then how old were you when you made those embryos? Your loss rate should still track with the time that they were frozen, and then how were these embryos frozen? What technology did we use? Did we use slow freeze or did we use vitrification? That doesn't affect aneuploidy, but does affect survival rates and implantation rates.
Gotcha. Okay, these are all such important things. It's hard not to get overwhelmed. Even as your answers, I'm going, oh, geez, maybe I should make some new embryos, not from my unfertilized eggs that I still have frozen. So I want to take it back to break down then. There are still genetic things that can impact a pregnancy. Can you give us even just 1 or 2 examples of what genetically, even when you have all 46 chromosomes, what genetically could lead to pregnancy loss before the end of first trimester?
So there's things called, there are some saying triploidy or polyploidy, so where you have all chromosomes, but there's more than 2 copies.
And you wouldn't pick that up on
some of these, a lot of PGT testing does not test for this now, although some more and more platforms are testing for polyploidy. Okay. There's something called uniparental disomy, where let's say you're supposed to have 2 chromosome 15s, but one is supposed to come from your mom and one is supposed to come from your dad. And what if the 2 chromosomes get stuck together and you get 2 chromosomes from your dad and nothing from your mom? That can cause potentially issues. There's a lot of things that we don't have identified, and I'm not a genetic counselor, so the genetics people are looking at this in great detail, and they probably do have identified some other genes, but it's not ready for clinical use yet, a lot of these things. I think there's stuff we can't test for. There's epigenetic factors and epigenetics is not something we understand very well. And certainly I don't understand it very well. It's an evolving science. So,
and let's define that. As I understand it, epigenetics is when you have environmental impact that can change the genes themselves. So
right. The function of the genes, the expression of the genes, or the non-expression of the genes.
Right.
Yes.
Right.
Yeah.
Right. And
but
it
is right now. It's a very general term because so it's and it's fascinating stuff. But like genetics is for doctors, even ones who deal with genetics every day, like we do in reproductive medicine, I feel like every day I'm drinking from the fire hose. I cannot believe how much information is coming out. It's not easy. So I think for when patients hear conflicting information, sometimes it's a reflection of changing technology, really different backgrounds and genetic training, and also controversies that exist in PGT. And whatever technology we're using, I'm always surprised. And Alice, you and I go to these meetings all the time where we get to talk to some of the leading genetic scientists in the entire world, and we could have the same conversation with two different scientists, both of whom we respect enormously, and they could have completely opposing opinions, right? And I mean, we've both been in that situation. So I think patients have to understand there's a lot of gray. It's like really exciting that all this technology is out there, but we don't have all the answers.
I mean, I almost look at somebody's gut to tell them what to do more so even, in this scenario than the science because of that, because it's a little, you can actually get so overwhelmed and bogged down in kind of the data and what does this mean for me, when sometimes you just have to trust your gut. Like, hey, I don't think that my body wants me to carry another pregnancy. So maybe I need to consider a surrogate if that's financially possible, or if I need to go, with one of these programs, that we've set up even with MedAnswers, that are outside the US that are tried and true, but more affordable. Or, maybe in this scenario, because it was so difficult to find one normal, that was PGT tested, but was a normal, it took 3 rounds at this age to get a normal, is it also time to consider an egg donor? Maybe she's capable of carrying. So, how does somebody decide
it's so hard. And I think you start with trying to get as much information as you can. And once you understand that information, you have to realize that we don't have all the answers. We have information, but we do not have the crystal ball, and we cannot tell you the right thing to do, because usually there's multiple right things to do. Sorry, I'll just close the door here.
Yeah, that I think is really challenging with all kinds of patient decision making, is that, with all these scenarios, there is always more than one path. It's even as simple as, do I try 6 IUIs before I try an IVF?
Right.
I mean, so much of decision making comes down to, what do I feel like I can personally endure? What is my personal risk mentally, physically, emotionally, and financially for the potential benefit? And what I've been counseling women lately, just in terms of their own decision making around egg freezing too, is, can I live with not getting the result that I want?
That's a great way to put it, Alice. I love that. I'm going to start using that. I like to frame things in no regrets, but that's another. I love that. Can I say it again?
Can I live with the outcome if it doesn't work?
Okay, I think we have to
with it if it doesn't work.
Have to post that in the notes in caps, and okay, because that, I definitely want to use that. I think that's a great way to frame the question, because after you digest like a boatload of crazy information and then feel totally overwhelmed, you have to break it down to some of these simple principles. Can I live with an outcome that is not expected, right? And I want to, at the end of the day, I want to be able to say, I don't have a crystal ball. I don't have complete control over this situation, but I was informed and I was counseled, and I found doctors and caretakers for me that I trusted and I felt comfortable with. And ultimately, at the end of the day, I made the right decision for myself at that time.
Exactly.
You want to be able to sleep at night. You want to be able to look at yourself in the mirror and say, I didn't know this was going to happen. I made this decision because of these reasons, and it was the right one at the time. And you can't really look back and beat yourself up, because none of us has a crystal ball.
Exactly. That is I think so much of this painful part of the journey for individuals and for couples is the kind of spiritual letting go, whatever people's religion or spirituality is, the human spirit of the letting go process of the devastation or the negative outcome or the loss itself. And there is a grieving process. People don't just get there overnight. There are stages of grief, and sometimes people boomerang from, I can't ever do this again, to I must try this again, and that's a boomerang that happens as hormones are rebalancing and emotions are rebalancing, and they're going through all these stages of grief.
Yeah.
So I would like to address what is actually tested when you go through a loss, if you have the fetal tissue or even a portion of the fetal tissue to test. If you've already
the recommendation, in somebody who's been through PGT, obviously they're going to check the tissue. They do a routine pathologic diagnosis, which they have to do on everybody. That's like kind of in a lot of states, it's kind of mandated by law. You can't just take tissue without looking at it under the microscope. So that's just routine. And really that's just going to say pregnancy or not pregnancy tissue. Sometimes it might show up in 12 weeks. It's not going to show that much, but it might show up things like infection, evidence for infection or things like that. And basically, the patient should say to their doctor, I really want to know, do you think we can get some answers from this tissue? You should say that to the physician before the tissue is taken or sent off anywhere, because the bottom line is if it's your first miscarriage, it is not at all routine or standard of care to do any kind of testing beyond that. And a lot of people want to know the genetics on their testing, and that can be expensive depending upon what your insurance is, and may not be covered, especially if it's your first pregnancy loss. So the arrangements should be made with your doctor ahead of time. That should be made clear, because it's definitely not routine. Now, in infertility, we test everything because that's our wheelhouse. That's what we do.
By the time somebody's 12 weeks, they're not even in your care anymore, because you've graduated them at week 9, correct? So then there's a little bit of a gap too, I feel like, there with IVF pregnancies and kind of standard OBGYN care, because maybe the expectation is a little bit different. And at that first appointment with my OBGYN, going in and saying like, look, this was my second frozen embryo transfer. Here's my checklist. Here's my plan. If I have a miscarriage, this is what I want done.
Right.
What kind of...
You also have to make sure that the OBGYN doesn't say, oh, you had genetic testing, well, you don't need any prenatal testing. So that's another issue that we have to speak up about. Pre-implantation genetic testing of your embryo is not the same as testing the pregnancy, and you deserve all the same testing that everybody else gets. Even if they didn't, everybody, whether they had genetic testing on their embryo or not, still needs
this comes up on the message board. Right. This comes up, Serena, on the message boards all the time. It's all over the Facebook groups. It's like, oh no, I already did, PGT. I already have these genetically tested embryos. So then if I'm offered NIPT, the answer is yes, I want NIPT.
Yes, absolutely.
Okay. Because the pregnancy, the genetics of the pregnancy do not equal just the genetics of PGT. Right. Because it looks at different things, correct?
Especially when you have non-invasive prenatal testing options. Okay, invasive like chorionic villus sampling or amnio are a little bit different because they have a loss rate associated with those procedures.
Right.
You're actually sticking a needle into the pregnancy. So I wouldn't be jumping around doing that so quickly without really understanding the pros and the cons. But NIPT is that's a little bit of blood work and an ultrasound like that. So there's really no downside to it, and those are the standard guidelines. So if your insurance covers it for other people, they should definitely cover it for you, whether you did PGT or not.
Got it. Okay, that's really great. I want to underscore that too. So we are advocating that even if you have a genetically tested embryo that had all 46 chromosomes, it was considered the normal one, no mosaicism, what have you. Just in the best case scenario, we're still advocating that you access non-invasive prenatal testing called NIPT. It only involves a blood draw and an
And
ultrasound.
then some people also have access to first trimester screening where they
Right.
measure the
We have that in California.
nucleolucency on ultrasound. So there's a lot of this prenatal testing available. There's a lot of acronyms available for it. And like if it's available to talk with a genetic counselor, early in your OB journey, that's like a great option to see what all the different options are.
Right, got it.
And PGT at its best, is 5 to 10 cells from the trophectoderm, the placental part. So we're not testing this is not testing the baby. It's not testing the pregnancy. And at best it's 97% accurate. This is nowhere near 100%.
Right. Oh gosh, I think that what you just said there is really important too. Just to reiterate that. So you're not testing your potential baby. You're testing a part of the embryo that ends up becoming the placenta itself.
Exactly. So it could be very different. Now, then people are like, well, why should I do PGT at all? And it's very expensive. It's not covered by insurance. It may not be worthwhile for you to do it. It's not for everybody. And but when we do it, it's about embryo selection and risk reduction. So it can be helpful. It's not 100%, but it can definitely be helpful for a lot of people.
Those are really high though, Serena. I mean, that sort of goes back to like the extraordinary, miraculous, that any babies ever, go through such a journey to like be brought to life. I think about that, like it measures the placenta, yet it's still 97% accurate. And that's extraordinarily high in my book. I mean, I remember when they were counseling me on whether I should do egg freezing or embryo freezing, and they said egg freezing alone had a 2 to 3% chance of working. And I was like, that's not the odds I'm playing. That was back before vitrification, which is why I chose a sperm donor at the time and made embryos. Yeah. But to hear that success rate, that brings us a level of calm, brings me a level of calm at the stage I'm at, right? But as I'm hearing it, there's so many checkpoints in the IVF process, and that's why it's so hard for any of us to relax, even after we get the positive pregnancy test.
I know. After you've been through like a journey like IVF or any kind of infertility journey or anything, that it's really, really stressful, and we want, self-care is so important. You talked about it a little bit at the beginning. And it's not that, we want you to relax because then if you relax, everything will be fine, because that's just blaming the victim. It's more that this process is stressful, and you being healthy in your body and your mind will definitely make everything go much more smoothly for you.
Well, because it's about feeding kind of mind, body, soul with the things that you need to deal with each checkpoint. Right. Yes. It's sort of about that. It's like, I want to put a protective shield around all of our patients and all of our users, just to say, we get it. This is one of many checkpoints that you still have to get through. And we know that those 40 weeks, if we get to 40 weeks, like we know that every single week, something pops up into your brain of like, what can go wrong? And then I didn't relax until I got to week 36. And then I still wasn't relaxed because I didn't believe anybody that I didn't have twins, so I was still having twin anxiety dreams, so I mean, these are the things that are just, that is unique to our patient population. They're unique to our community. And as you said, and why we do these Monday motivations is to break down some of these terms and some of these ideas in kind of actionable, very conversational steps. So
exactly. And we want to empower all of everybody in this community to communicate with their doctor, because that does help your doctor, and it makes a difference, and it helps it just raises the bar on the individualization that you will receive in your care. I think it just makes overall for a better experience. I think that you should feel comfortable being able to raise a lot of these questions with your doctor. And if you ever feel like you're not being people are not listening to you, and you're not being respected in terms of issues that you raise, then maybe that's not a relationship that's really working for you. Then something really has to change, because I really feel people should feel comfortable in being able to bring up these issues and concerns. You're not a physician necessarily, but you still deserve to get answers to your questions.
Absolutely. And then sometimes, for whatever reason, that's the toughest thing for people to do. A, I don't think they know what questions to ask. And B, sometimes they feel that the relationship with their doctor is so authoritative, they feel uncomfortable asking those questions.
So I really like it when people have a buddy. Like maybe your husband
Yeah.
can't come in person. Can they be Skyped in? Can they be on the phone? Can you bring a girlfriend, or your cousin or your neighbor, or somebody who's been through it before, like just somebody to like take notes and to listen, because they're not going to be so emotional. And when you're really emotional, it's very hard
to think straight. Yes,
to
it's hard to
concentrate. Yes,
Mhm.
absolutely.
It's
That
very
definitely
difficult. Yeah,
affects you.
for sure. There's an impact on clarity of thought and clarity of
Absolutely,
communication.
absolutely. So it definitely, I always appreciate it when people bring along a buddy, because to me it makes my job much easier, because I know there's more than one set of ears listening, and there's a lot of information to absorb, and the two of you are gonna absorb it better than just one set of ears.
Agreed. Yeah, agreed. And you also hear things differently. We talk a
Yes,
lot about that with team building in the company, that everyone has listening filters. And because you have listening filters, it pays to have someone who isn't you, who also
yes.
is hearing different things in a different way, and it's landing a little bit differently. And then together you can kind of piece a concrete, understanding of what unfolded in front of you. I do want to ask a technical point of clarification on when it comes time to test the tissue itself. So
Yes.
we know that there's different ways to do genetic testing of embryos, and there's even a non-invasive way to do genetic testing of embryos now too, where they can test the culture media and get some information as well. And I know that the testing is done through NGS. We're throwing around a lot of terms. If I went to test my fetal tissue that we had available after a pregnancy loss, which even just thinking about coping with that is just so devastating. Is there also different types of testing though that I need to know about and that I need to discuss with my doctor? Are there different techniques as well?
Well,
Is it a different genetic
I
panel?
think most of the time, the vast majority of labs will have karyotyping available. So karyotyping is like been around for a really long time. They look at the cells, they grow them in culture, and it's this old fashioned thing where they look under a microscope. But if they can get the test to work, it's a very good way to look at the chromosomes and the genetics. There's
Okay.
also a lot of places are also using, next generation sequencing,
The end.
which is in some ways can be a lot easier for the lab, because they don't. My understanding is they don't have to grow the cells, and a lot of newer companies are using this. It's not clear that insurance companies are really covering this type of testing well at all. It's becoming controversial, and some people that have restrictive plans, sometimes it can be really difficult to figure that out. A lot of these companies know that insurance is an issue and try to work on that and help you with that, but
Okay.
everybody's different. So I think karyotyping should definitely be available, because it should be available in any pathology lab, and they should be
Sure.
just check the chromosomes. And then some of this newer type testing can be advantageous, because sometimes the old-fashioned karyotype, you have more situations, a higher rate of no results, because they require the cells to grow. And there's also, because the cells are all mushed together with the mother cells, when you get a 46XX result, that often is the mother's chromosomes and not the baby's chromosomes. So the
Okay.
NGS testing has the ability, this newer testing has the ability to say, okay, these are the mom cells and these are the baby cells, or the pregnancy
Wow.
cells, and we can differentiate, yes, this result belongs to the pregnancy and is not maternal contamination.
Oh my
So,
goodness, that sounds really important
yeah, but
for doctor data.
again, this is newer testing. It's just
Sure.
starting to be used in products of conception, and the insurance has definitely been a barrier.
Mm. So it's another insurance issue we have to go to work on.
Yeah.
Yeah. So how would you, I mean, at the end of the day, when we have a patient like this in front of us, how do we counsel them on, yes, do another egg retrieval at the age of 44 again, and let's do one more egg retrieval,
That,
and see if we
Alice,
get
that
into
is
normal,
so,
or
so tough. I mean, if you look at the SART report, they don't really even talk about people that are 44 and 45 years old because the pregnancy rate is essentially close to zero. And it's, it's very hard because of course there are exceptions to the rule. And of course, if we're trying to push the envelope, how are we going to push the envelope if we don't push the envelope?
right,
But really, when you look at standards, we are obligated to tell people like the pregnancy rate at 43 and 44 nationally is close to zero, and the United States has some of the best pregnancy rates and the best IVF labs in the country. And you have to say, we don't really have a lot of data, and you seem healthy and healthy for pregnancy and healthy for IVF. So if you are going to try this again with your own eggs, this is going to have to be your decision. And there are definitely a lot of programs that have very standard guidelines, and will they'll be like, sorry, we can't do it for you. We you have to do, it's donor egg or nothing,
right,
because just because of that data. And I
sure,
don't think either of those approaches is necessarily wrong, but every program has their own philosophies. And I also think that ultimately, especially in my over 40 patients that have high AMHs and make a lot of nice looking embryos, it's really, really tough because it's really hard to think about, oh, I had like 2 or 3 gorgeous embryos and none of them is making a baby. But
right,
there's also that data that at 44, the take home baby rate, even if you made 100, even if you had 100 eggs in the lab, your take home baby rate might still only be 50%. And I don't know anybody who can make 100 eggs.
no, yeah, I
Like
don't,
right now we can't do that.
yeah, of course not.
So I feel like I feel like there's so many factors that call into play, and there is not one
Not a
right
clear
decision
answer.
for
I
anybody.
get that. I get that. But ethically, it does seem that probably if we asked all of the IVF doctors in our network, probably ethically, they would vote on the side of egg donation, whether you want to carry or not, just because of the statistics.
Yeah, yeah. I think a lot of people would be like, this is should be doing, because why are we doing something that does not demonstrate like a reasonable take home baby rate? Now,
Exactly.
what's reasonable, what's not. I've had patients say, well, 50% take home baby rate, that's terrible, I'm not doing that. And I'm like, hello, that's a really good pregnancy rate. And I've also had people in my office saying, 1%, doc, you're not saying zero, so I'm ready to go. So
Right.
like
Yeah.
there's so much more than science and medicine involved in this.
Right, right. Okay. Well, in this particular case, I would expect, some genetic testing to ensure that there's not the blood disorder that you mentioned at the top of the
Absolutely. Like,
episode.
obviously we want her to be safe. Like,
Exactly.
hopefully this was just like a bad, like being hit by lightning, which
Right.
it certainly could be. The vast majority of terrible bleeds in obstetrical situations are just like pregnant women. This
Right.
can happen to pregnant women,
Right.
but that's a simple test. We can just make sure, see a
Yeah.
hematologist, make sure you don't have a bleeding problem, and look at all your supplements and your vitamins and your foods, and
And
just
so
make
they're
sure
not
you're not
contributing to that.
increasing
Yes.
your risks, right? And then, after a big bleed, you have to make sure the uterus is okay. Like, is there
Yeah.
any scarring? Is there a piece of
Right.
placenta that's stuck? What's going on? How does your OB feel about your uterus? How does your reproductive endocrinologist feel about your uterus?
Right.
Is it okay for you? And is it okay for an embryo?
Right.
And then, the whole, should I make another embryo using my own eggs? That's a really tough question at this age. It
Yeah.
really, she already did it once, but what was the cost of making that one embryo,
Exactly.
and would that really happen again? I don't really know. There's so many things to look at.
Sure, sure. But even if this patient could, it is an outlier. I think that
Yeah.
that's kind of the key. That
Yeah,
it
it is definitely an outlier to have a
yeah,
44-year-old with a normal embryo. Yes,
yeah,
absolutely. That is hard. That
yeah.
is not easy to do.
Yes, yes. Okay, got it. I think this was one of our most critical conversations. It's one of the toughest to have because it includes such heartbreaking, real life scenarios. Every other week, I feel that there's a new celebrity in the media who has been very open about their own pregnancy loss and their own experience. And I'm so grateful to them for being vocal about it, so that we can destigmatize these things and have them, not happen, but, in a vacuum, where filled with shame and so forth. There's nothing shameful about it. This is not your fault. This is, like Serena said, in some cases, it's just like getting hit by lightning. Like, you can't predict it. You can't prevent it. We can collect all the data that we can have. But at the end of the day, what we're here to do is just empower each and every one of our community members with the facts and the types of questions and sort of the next steps, that if you find yourself in one of these scenarios, or a loved one is in one of these scenarios, you're armed with how to cope. You're armed with, at least how to interact with your provider. So Serena, thank you for being one of those just amazing docs that everybody is comfortable with, and that people do ask questions of, because you make it such a safe space, and then for sharing that wisdom with everybody else. I'm so happy to be back in 2020. And this is your weekly Monday motivation with Alice and Serena.
I'll see you next week, Alice. It's great. Great questions. Thank you.
Serena. Okay, take care, everyone.